Welcome, everyone. Thank you so much for joining our webinar. This is hosted by the AAST Prevention Committee. We are going to be presenting a lot of very useful information, emerging evidence and new initiatives in IPV care and prevention. I'm Dr. Christine Castater. I am a trauma and critical care surgeon at Grady Memorial Hospital. I'm a vice chair of Access, Engagement, and Justice, and also assistant professor of surgery at Morehouse School of Medicine. I'm going to take a minute to introduce my amazing panelists who outshine me by far. We have Dr. Stephanie Bonne, who many people know. She's a professor of surgery at Wake Forest University School of Medicine and practices trauma surgery at Advocate Wake Forest Health at Christ Medical Center in South Chicago. She's currently the chair of the Committee on Intimate Partner Violence for the American College of Surgeons and has been deeply involved in work on preventing intimate partner violence through the AAST, EAST, AWS, and also the college. We also have Dr. Tanya Zakrison. She's a professor of surgery at the University of Chicago Medicine. We have a lot of Chicagoans here in the house. And she's a trauma surgeon who has pioneered innovative approaches to addressing social determinants of health following injury. She's a co-founder of the Recovery Legal Care, and which is a groundbreaking medical legal partnership embedded in the trauma center that provides legal advocacy for survivors of firearm violence, addressing health-harming legal needs such as housing instability, employment discrimination, and access to benefits. I could go on and on about her, but I will also move on to talk about some of our other panelists. We have Dr. Amanda Teichman. She's an assistant professor of surgery in the Division of Acute Care Surgery at Rutgers, Robert Wood Johnson Medical Center. She got her bachelor's degree in mathematics from Rutgers University and a medical degree from Drexel. She's working on completing an MPH at Johns Hopkins. She did general surgery residency at Hahnemann University and fellowship at Cooper in trauma and critical care. She's double boarded and works as a acute care surgeon and intensivist at Robert Wood Johnson University Hospital. She's also the director of quality improvement for the Division of Acute Care Surgery. And last but not least, we have, Dr. Joseph. She has over 20 years of experience in academic medicine and trauma systems leadership. She's built a legacy of advancing surgical and critical care quality through frontline guidance and systems innovation. She had served as the chief of trauma and acute care surgery at New York University's Langone Hospital, Long Island, for more than 6 years, and that has led multiple multidisciplinary initiatives focused on performance improvement, peer review, transfusion safety, and also surgical critical care metrics. So we are very lucky to have all of these panelists. I'm going to move on and go to Dr. Bonne. Dr. Bonne is going to give us some introductory remarks about intimate partner violence. And before she starts, I just want to say that that the AAST no longer offers CME for live grand rounds. If CME is available for the archived version of the grand rounds, those who watch today's webinar will receive an email once the archived version is available on the AAST website, and that will prompt you to log in and claim your CME. So then you can get CME in the future. Thank you, Dr. Bonne, for starting us off.
So thanks for everybody for joining us today. This is a key priority for the Prevention Committee for the AAST, which I chair and Dr. Joseph co-chairs. I really appreciate everybody joining us. October is Intimate Partner Violence Awareness Month, which is why we timed this webinar to be here today. I'm just going to give an introduction and some background on some of what I've learned about intimate partner violence over the years being involved in this space, and then we'll move on to our additional talks. So just to define the scope of IPV, the forms of IPV we traditionally think about as physical violence, but it can also include sexual assaults, psychological aggression, stalking, or digital abuse increasingly in our digital world, and it also includes financial abuse. For those of you on this talk, there is a coordinating talk with, or there's another talk happening with the Intimate Partner Violence Committee of the American College of Surgeons on financial abuse and how that plays into intimate partner violence. And so if you are a member of the college, those are recorded and available, and I would encourage you to find that as well. It should be available on their YouTube channel. IPV affects all types of intimate relationships. I think it's important to understand that the legislation is often geared toward those in married relationships and not those in dating relationships or stalking. And these occur regardless of gender, orientation, socioeconomic background. Many victims experience IPV before the age of 25, which highlights the reasons that we need to do early intervention and education in this space, and it can cause lasting problems. In the United States, over 35% of women and 28% of men have experienced intimate partner violence at some point in their lifetime. But nearly 2/3 of college students cannot identify abuse that's happening around them or identify the signs of dating abuse. So this is really, complicates if we're not learning about this as young people. Nearly half of all adults have experienced some sort of psychological aggression from an intimate partner. So this is very widespread, and victims may experience financial abuse, coercion, or psychological manipulation, making recognition very difficult, and options to leave relationships or move away from the individual that is causing the IPV may feel overwhelming. About 1 in 3 women globally experience this, according to the World Health Organization, and 1 in 5 girls age 15 to 19 report intimate partner violence. So it really is a big problem. In the United States, again, over 1 in 3 women and 1 in 4 men report lifetime IPV, according to the CDC, and which amounts to 61 million men and 61 million women and 53 million men. So what is some of the impact and consequences? There is a $12 billion annual societal cost of intimate partner violence that we know of. That includes medical, legal, and productivity losses. But because this is a widely underreported problem, these statistics are likely also really underreported. Victims may suffer chronic health issues like PTSD, depression, and increasing healthcare usage. Despite that, about 40% of victims of intimate partner violence lack any sort of adequate access to healthcare. We need to think about this when we think about our patients, specifically in vulnerable populations or patients who don't have as much access to healthcare, may be at increased risk or may be fearful or may not have access to healthcare because of things like immigration status or socioeconomic status. IPV can lead to disabilities and create more economic instability in the family. And there's a lot of stigma around this problem. So if we can take one thing away from the webinar today, I would say destigmatizing this problem, talking about it in the open so that it's normalized, and we can continue to have discussions with one another, and we can make ourselves, our colleagues, and our patients feel comfortable discussing this problem. It's probably the one key takeaway that I would hope that everybody comes away from this. So risk factors, there are socioeconomic risk factors that we know to be associated with IPV that include food insecurity and poverty. There are psychological contributors such as relationship dissatisfaction, emotional intervention needs, insecure attachments. And then there's also, some policies that can create issues with IPV. So, some of the policies that we're seeing in our country around abortion and pregnancy care can cause financial and emotional stress. We know that women who are pregnant are at extremely high risk of intimate partner violence, and that the increasing stress around pregnancy and focus on what's going on around pregnancy can even further exacerbate that problem. Risk factors include childhood exposure to violence, substance abuse, and poverty. Protective factors include supportive relationships, economic stability, and healthy relationships. And then again, we've seen this first victimization before age 18 as an emerging trend. And we're seeing a lot of tech facilitated intimate partner violence. So image-based abuse, people sending pictures to each other online and creating abusive situations, including things like modification of pictures using AI, et cetera. What to know about children. children often witness or experience intimate partner violence within their households, which affects their safety. They have increased risks of trauma, suicide, substance abuse, and behavioral problems. Children who are exposed to IPV often face academic struggle, social isolation, and higher chances of being involved in the criminal justice system. And then we know that counseling, safe housing, education support, and particularly screening and normalizing this discussion among in schools and among counselors and among those who work with children, including our pediatrics colleagues, is extremely important. CDC has some recommendations on prevention of intimate partner violence. Notably, I will just say that the CDC's work on intimate partner violence has just been defunded. So, part of what we can do as physicians is continue to advocate for resources for the CDC to work in this space. But what we have right now is what we had as of a few months ago, and the work has since been deprioritized and defunded by the federal government. We do they do recommend preventing intimate partner violence through education, community engagement, and policy reform, so a true public health approach. Collaborative community interventions among law enforcement, healthcare, and social services that improves victim services when there's different anchor organizations within a community that are working together, creating safe housing and policy resources, and then teaching conflict resolution and really teaching children about healthy relationships. What you can do is recognize IPV signs and support victims. Share your resources with your friends and colleagues. So if you have resources for screening, and really normalize the conversation. Organizations can have training and policy, so training nurses and staff in your hospitals to screen, and really meaningful screening and meaningful intervention. I can't stress this enough. It is not enough for a nurse to be with their back turned to the patient in a corner of a room on Epic, filling out a checklist, and not making eye contact with the patient and saying, "Do you feel safe in your home?" It's just not going to get it done. But we also need to follow our screenings with meaningful interventions, and this is a space where trauma in general, for many of our screenings, we fall short in that we are able to identify a problem, but then we're often not really able to offer much in the way of fixing it. Communities can, support survivors, can support collaboration and community support solutions. Here's some key resources: the CDC, the World Health Organization, and the National Domestic Violence Hotline. I encourage everybody to sort of screenshot this or take a look at it and take a look at these resources. And then finally, I just, because this is a particular issue, I want to bring up intimate partner violence among our surgical community and among our colleagues. We are not immune to this problem as physicians. A lot of people think that because of our, professional standing or because of our generally higher socioeconomic status that we are immune to this problem, and we are not. 24% of all physicians have reported intimate partner violence, but we know that this is probably also very unreported because of the stigmatization, particularly among our professional circles. And you can see that this has come in the form of stalking, sexual abuse, physical abuse. Although in the general population, the highest risk is at reproductive age. In physicians, the higher risk is actually among older women, age 55 and over. And there are potentially as many as 400,000 women physicians that are experiencing intimate partner violence, but we have no idea. We don't actually really know because people aren't talking about it, and we have not destigmatized this in our community. In 2017, the American College of Surgeons created the Intimate Partner Violence Task Force, which is now a committee of the college, aimed at raising awareness of the incidence of IPV specifically in the surgical community, educating surgeons on their risks among themselves, their colleagues, their partners, and to provide resources. This came in the wake of the death of Sherilyn Gordon Burroughs, who is an extremely talented transplant surgeon and surgical educator in Texas, and she died at the hands of her partner back in 2017, and started kind of a movement at that time, there was a bulletin. I encourage you, if you're interested in this topic, to go back and look this up. You can find all the old bulletin articles and issues online through the American College of Surgeons website. And we specifically discussed this in the surgical community. This committee comes from a place of recognizing that all socioeconomic classes and employment statuses are at risk of IPV. We provide resources for surgeons to talk to your partners, to talk to the people that you work with, offering resources and helping people develop a plan, and provide resources for surgical communities who have been affected by IPV, for example, a residency program that loses a resident. Which has happened, unfortunately. Here are 3 additional members of our community who are medical students and residents who have been lost in the last 2 years to intimate partner violence. So this continues to be a problem in our surgical community as well, and we want to continue to address it both in our patients and in our own community. So with that, I will move along, and I think we'll do questions at the end.
All right, at this point, Dr. Zakrison, you will present some of your very interesting research. Thank you so much.
Great. Thank you so much, Dr. Castater. And also thank you so much, Dr. Bonne, for an excellent overview and introduction. So it is a true privilege to be here sharing with you and with the broader AAST community. And yes, I'm privileged to share some research that we've done as a team on the state level analysis of intimate partner violence, abortion access in particular, and its role in peripartum homicide. And this is basically stems from a JACS paper rather, from 2024, largely focused with researchers, multidisciplinary researchers in trauma surgery and OBGYN here locally at the University of Chicago and beyond. I have no disclosures specific to this research. So we wanted as a team to ask the question, who is specifically at risk for peripartum homicide, and does abortion access matter? Because this was coming out of the Dobbs decision in 2022. A lot of our junior trainees, such as Grace Keegan, who was the medical student that led this research, started asking questions about how is this going to impact the overall state of health of women in general. So our first objective was to characterize peripartum homicide demographics and risk factors using a particular database, which I've been privileged and able to use, even though it's like quite a morbid database, but the National Violent Deaths Reporting System. And we did that over 2 years from 2018 to 2020. And then we want to analyze state level peripartum homicide rates based on abortion access policies, which were in flux and changing at that time. So again, anyone can access the NVDRS. And what's nice about it currently since 2020 is it's broader, whereas before it had only like half the states included. Now we've moved along to 46 states. And I think by now, probably the full 50 states included, although there is still some incomplete data with that. So what do we mean by peripartum? For our definitions, that's currently pregnant or less than a year postpartum. And then non-peripartum were any females between the ages of 20 to 50 years. And for state classification, in terms of restrictive state laws vis-a-vis abortion, that meant TRAP laws, and that's targeted regulation of abortion providers, which is, excuse me, it's exactly as it sounds. It's sort of ways to control those healthcare providers that are offering abortions, whether it's through felony charges or even simple things like hallway measurements and clinic room measurements in offices and clinics that are preventing abortion or providing abortion, and saying they don't fit certain specifications, so you have to close your clinic. So they're very extremely cumbersome laws, medication limits, insurance limits, all these things that add up to being a restrictive state by definition. Protective is the opposite, and neutral is neither of them. And so what do we find? So over the 2 years of our data analysis using NVDRS, we had our peripartum group compared to the non-peripartum homicide victims, because everyone in that database has died a violent death, as the name implies. So we did find something that was not a surprise. And again, we learned about this as a risk factor in Dr. Bonne's excellent introduction, how we're seeing more homicides in peripartum women. Statistically so, all of this is statistically significant. And our peripartum victims were younger, not as educated and less likely to be married. Although, again, to reiterate, across the country in general, we're talking about something in terms of intimate partner homicide, something that does cross class lines. It affects everyone. One thing that's important to note is we noticed actually that disproportionately Black women were experiencing peripartum homicide to a rate of like 6.7 times higher. And we'll talk about that, where we saw nearly Black and like equal Black and white victims in the peripartum group. And there's not much time to get into this, but it's an extremely important point. That is being part of the global sort of a national erasure of our history and our economic realities. But that structural racism will have a tendency to trap Black women in violent relationships through a variety of different mechanisms. And a lot of that is because when the educational status is the same compared to white men, for example, if it's a bachelor's degree or a post-secondary, or graduate level degree, Black women will earn 2/3 of what Black men or white men will earn, with the highest student debt burden of any group. And also that wage gap actually worsens with age, and it sort of approaches 50% or even less of what white men earn once you approach the age of 50, 60, and 70 years. And it will take approximately 350 years to achieve pay parity. So what happens when you're economically dependent on someone? You have less options. And so it's very difficult to leave abusive partners. This is just a very vague overview of that. But one of the myriad mechanisms in which structural racism plays a role in this, as it does virtually most etiologies of harm in this country. But when we talk about intimate partner violence in general, especially intimate partner homicide, firearms also figure prominently in this, with close to 2/3 of peripartum women being killed by firearms. What's interesting also is we're seeing that there was, yes, an argument that preceded homicide, but not all the time. But in the vast majority, almost all of these cases, this was non-random violence. Mental health problems, if anything, were probably lower than the prevalence in the country without, but many of these homicides are occurring at home. So it's very likely that IPV is actually underreported because of the nature of 97% of this being non-random violence, meaning there was a connection, there was an interaction, a known interaction between people when the homicide occurred. So, maybe it's not a surprise, and there's also other emerging data about this, how states that do restrict access to abortions had a 75% higher peripartum homicide rate, with the highest rates being in Louisiana, Missouri, and Nevada. And we said, well, maybe those states just have lots of homicide, lots of firearm homicide, for example. And so we used males as a control group, but there's no trend, no similar trend across states when comparing protective, neutral, and restrictive abortion laws. So what we saw with this research is that intimate partner violence-related maternal mortality, or intimate partner homicide, is indeed a crisis. And intimate partner homicide is indeed the leading cause of maternal mortality in the US, with peripartum individuals at 50% higher risk of this. We did see how structural racism does increase IPV homicide vulnerability. This study didn't get into the specific instances of structural racism of the cases that were reported, but this is just built on the body of literature and knowledge that we know that exists, with Black women representing 47% of peripartum homicide. Firearm violence also, as we know, figures prominently, unfortunately, in intimate partner homicide, with 63% of these homicides involving firearms. And it's important to know that firearm relinquishment laws for domestic violence is a tool that that has already demonstrated that can prevent intimate partner homicide. Unfortunately, the relinquishment laws are only in existence in around 19 states in our country. And abortion restrictions enable, or at least are associated with, intimate partner violence. And so that's very important to discuss and look at deeper, in a deeper analysis. But basically, when you're forcing someone to be pregnant, it increases your exposure to intimate partner violence and therefore intimate partner homicides. Again, and it prevents victims from escaping abusive partners. So we'll hear more about call to action, and I am a firm and strong believer of universal IPV screening for all trauma patients. In fact, we did do studies on this in the past, and that means for all genders. And in fact, at the University of Chicago, we have slightly more men that present after intimate partner violence than women, and there is a bidirectionality to that. So that's important to address as well. But abortion access protections are indeed essential. And I'd like to highlight the invited commentary to our paper done by Dr. Haddad and Dr. Kaufman, who are brilliant trauma surgeons, and really highlighted the strengths of the paper, and then also the important considerations and our limitations in terms of this is not a causal paper. But the broader context is really important in terms of what they highlighted, where states that do expand Medicaid have lower maternal mortality, especially for Black women. And that's important to know because with our big, beautiful bill, we just chopped $1 trillion to Medicaid over 10 years. So the impact of that will be likely devastating on multiple levels. And prevention has to be multifactorial. I do invite the audience to read other literature related to this by the Himmelstein-Wohlhendler group. They're the original Harvard primary care researchers that actually studied the impact of patient dumping and brought you the EMTALA law. So they looked at rape-related pregnancies in 14 states with total abortion bans, and over a year to a year and a half, and they found that there was close to 65,000 rape-related pregnancies in these states, which is a phenomenon that we're seeing all across the country, where 25 million women have a lifetime risk of being raped, and of that, around 3 million will have a lifetime risk of being pregnant after being raped. And that's 2.1 million when you talk about rape by an intimate partner. And, we hear sometimes about states having, rape as an exception to the law. That seems to be window dressing, as they call it, because you have to file a police report, and the vast majority of people who have been sexually assaulted do not file reports. So this is indeed a massive human tragedy. And our prior research, also done by Grace Keegan, is interesting, just to focus on actually the critical cascade that the Dobbs decision has had on trauma care, because OBGYN programs really require specialized training for their residents in managing complex abortion procedures. If that is eliminated because of political legislation in different states, then the training programs do not meet ACGME accreditation, and they will close, they will end, and trainees will go elsewhere. And then what happens is trauma centers that are level 1 or level 2 trauma centers cannot maintain their accreditation, because we need OBGYNs to be a trauma center the way we need orthopods and neurosurgeons, et cetera. So actually, it's interesting because the Dobbs decision is going to impact the survival of men, and in fact, all trauma patients, as trauma centers will be forced to close, especially in rural areas. So we looked in 2023 at this paper, how abortion restrictions harm trauma systems and increase violence. And the study I just finished was talking about the most severe outcome, peripartum homicide. And with that, I'd like to say thank you.
Thank you so much, Dr. Zakrison. We're going to move on to Dr. Joseph. We're going to be talking about some recent screening data, so I will move on to her. Are you able to share your screen?
Okay, yep. Sounds good. Get started and share my screen.
Dr.
We all
Zakrison,
went through this.
your data is just so heartbreaking, but so important for all of us to understand. Thank you.
Thank you.
So, thank you, everyone. And again, this is it cannot be overstated, the impact of intimate partner violence on the community. And it's a privilege to be here. Thank you to Dr. Castater for inviting me and to my esteemed colleagues. And I hope you're not seeing for some reason I can't do the closed captioning. I hope you're not seeing that. All right, so I do not have any disclosures that are applicable to this, but I felt it important to state that I am vice chair of the Committee on IPV. And the reason I say this is because often people will dismiss things that one says in the context of, well, there you have an inherent bias. And I think it's appropriate that one has bias towards IPV because, as we've talked about, there are things that are inappropriate and ways that we can use to prevent this. So you will hear these numbers in various ways touted over and over again. We talked about Dr. Bonnie spoke about the excellent introduction by Dr. Bonnie about what intimate partner violence is, the highest risk group, which are women ages 18 to 24, and this is globally. And also looking at the data still that intimate violence does affect men and women, but women being disproportionately more affected than men. It is important to understand that this is a global issue and that it is not unique to the United States. And in fact, data suggests that there are particular areas where there may be more prevalence, if you would. But what I really wanted to highlight here as we talk about the importance of screening. So this is interestingly, the paper is, the lead author is one of our co-panelists here, Dr. Amanda Teichman, and I think everybody on this panel were co-authors, is the sequelae of intimate partner violence. And when you hear these terrible stories or these frankly frightening information about the defunding of research in IPV or support for people with IPV and all the data that was presented by Dr. Zakrison, what is missed with these types of steps is the sequelae of IPV. And those are endless. And we'll talk about them over and over again, either mental health disorders, substance abuse disorders, physical injury, suicide, and/or homicide. And these are lasting things that go on throughout a person's lifetime. The key take home here is that IPV is preventable, and we are not, how shall we say, helpless when it comes to addressing this. And in this particular study, the idea was to identify how screening occurs and whether screening intervention, what was the result of having screening for IPV. Why is this even an issue? Well, victimized women are 3 times more likely to present to the ED as opposed to non-victimized women. You have the healthcare setting across all disciplines being a unique opportunity for identifying victims because you have the relationship between the physician and the doctor or the other healthcare provider who can query in a safe way for whether this person is a victim or not. And also aggressor. It's important to also understand that most aggressors, and several studies to suggest that the highest risk of being an aggressor is actually someone who's been a victim themselves or who've actually witnessed this. So an Eastern Association of the Surgery of Trauma multi-center trial found that 1 in 9 trauma patients are at risk for intimate partner and sexual violence. I mean, let's think about that for an instance. 1 in 9 patients. So we can interrupt the cycle. So this study was done, really was a review of existing studies. The purpose was really to provide an evidence-based review for screening. And I'm sorry, can you still see my screen? Yes, okay. And for screening practices in IPV, for IPV and trauma victims. So a systematic review of all adult ED trauma patients 18 and above. The inclusion criteria was directed at addressing the specified PICO questions, which really ultimately wanted to look at what happened for, did you have an outcome as in identifying victims earlier without screening as opposed to screening, and was there reduction in adverse outcomes? The case reports, editorials, abstracts, inability to address the PICO questions, this was excluded. And we started out with over 12,000 articles, which was subsequently reduced to 7,700 after over 4,000 duplicates were identified. And subsequent to that, ended up with 210 for full review, and then 204 were further excluded, meaning that there were only actually 7 articles that met criteria for screening. What was identified, and we'll talk a little bit more about this, is that no studies actually directly evaluated specific IPV interventions post-identification, which again is an opportunity for further research. But this particular review was able to demonstrate that there are protocols that are in place, and the idea was whether this actually made a difference. IPV was recognized in about 1 to 33.5% of participants, as compared to those 0.3 to 5.6% in those where there was no screening. So, I mean, this clearly demonstrates that in order to actually identify IPV, you have to ask about it. And this is really Dr. Bonne mentioned this earlier. We don't mean actually standing at the computer on Epic with your back turned. We mean asking in a thoughtful, careful way. And we'll talk about that a little bit more when we're trying to identify IPV. Due to the heterogeneity of the study, you could not actually do a meta-analysis. So the grade methodology was applied, and I know you guys are familiar with that. And because of the small number of studies, ultimately, as I stated, we settled on only 7 studies, which were primarily single centers. They were observational. There was no actual intervention. It's a question of like what had actually happened. And the results were that it was deemed to be low, but the committee, however, conditionally recommended implementing a universal screening for adults in the EDs and trauma centers. And the rationale behind this, despite having a low grade evidence, is that the actual implementation of the screening tool, it's low risk, it's a potentially high benefit. It's the same reason as, say, for example, trauma surgeons, we have a person come in who's hit their head and they're unconscious, and we screen their cervical spine, because the likelihood of having, while it may be less than 5%, actually having a significant spine injury, the sequelae of missing it could be catastrophic. So low risk, high benefit, and the screening protocols were more likely to identify more victims than non-standard. Obviously, as we mentioned earlier, there were limitations. It was a heterogeneous design. None of the studies actually looked at post-screening as to what happens when, and overall, as I said, low intervention. But what this brings up is, when you screen, how do you screen? There were several recommendations that came out of the study, but I want to talk a little bit about the different tools that exist. There are the brief tools, the HITS or the E-HITS, and HITS refers to hurt, insult, threaten, screen, partner violence, screen, and the expanded tools, as you can see, listed here. In the results of the study mentioned, or in actual any of the studies to date, no tool has actually proven to be definitively superior or not. These are all validated tools that they do identify persons, they identify victims, but with respect to whether one being superior, it really comes down to the feasibility and the ability to implement that tool at the institution. The recommendations that came out of this is really that there should be universal IPV screening, definitely in the ED and trauma setting, but also across other medical disciplines. This should be something that should be hardwired into the workflow. And it should not, and I know that we've all been at institutions where, yes, it's part of the intake for the patient, but it's done in such a cursory fashion. I really sometimes wonder how many patients are missed when this is actually done. Importantly, as with any intervention or any new process, outcomes should be tracked, and there should be ongoing research to strengthen the evidence base. The universal screening should be done in a private manner, as I stated before. It could be done by the triage or the primary nurse assessment. I want to point out too, in terms of limitations, as was mentioned in this study, while the focus is on the ED and the initial presentation of the patient, oftentimes this could be a high stress situation where the patient may not necessarily feel comfortable to speak at the time of first contact. So universal screening, in my mind, and I'm a very strong advocate like my colleagues here, should not just be when the person enters the ED. It should really continue throughout the course of the person's training and the person's admission. And as we continue to educate and become more educated about IPV, many of us are able to identify certain red flags, if you would, or certain concerns where you feel that it would be more appropriate to further interrogate. And that sounds like kind of the wrong word, or discuss with the patient whether they feel comfortable or not. I also want to point out that the presence of red flags, or the absence of quote unquote red flags, is not necessarily a end all be all, because as was pointed out earlier, there are several of us, and I say us meaning the surgical community, where people continue to be victims but do not necessarily demonstrate or present in the way that one would typically think. So once you have identified and screened that, when a person screens in, you want to make sure that the patient is safe. You want to assess imminent danger. There should be a warm handoff to the social worker or any advocacy resources. There should be a process in place that would help take it to the next step. It's not sufficient to, oh, this person is a victim, but there has to be a method by which, or a process by which that person is further assisted. Documentation and coding, of course, of these tools and continue to screen and track is essential. So if you look at it in a flow chart, it's that you want to actually identify select a tool that you can actually build into your EHR, whatever your electronic health system is, having that actually interwoven into the workflow, into the EHR, forces a person, whoever's doing the triage, to stop and address it. I would say you take one step further, though. People who are actually performing the triage actually need to be educated on the process by which they actually place questions to patients. You want to prioritize research. You want to, when you select your tool and build into HR, train staff, as I said it earlier. You want to define your response pathways. You want to be able to share materials. Let's say a person is unwilling to provide information or do anything further. You want to be able to give them tools, if you would, whether they be brochures or handout cards. I think it's at your center at Rutgers, Dr. Technician, that where you actually give this little lipstick bag that looks like a lipstick, and there's a little piece of paper in there with a number that a person can call, which is great. So this is in terms of best practice back in 2018. The USPSTF recommended that screening should occur in all women of reproductive age, and they should provide it and ongoing support or referral to services provided, and this was reaffirmed in 2025. The American College of Surgeons Best Practices for Trauma Center, as you can see, Dr. Bonne shared the toolkit that came out, and Dr. Bonne was one of the initial authors of that toolkit that came out after the unfortunate death of our colleague, Dr. Gordon Burroughs. And EAST adds ED's trauma-specific evidence-based support for implementing screen protocol. So I just want to end here, and again, we're just focusing on the paper here, but it is important to understand that IPV is a preventable disease, that it is costly not just because it's economically costly, it is that, but it is costly in terms of years of life lost, years in states of being unwell. It is important to note that the victims are more likely to present to the ED as compared to non-victims, and that they appear across all specialties. The physician, the surgeon, the healthcare provider has a unique opportunity to help break that cycle and to assist victims. And of course, the ongoing research is essential and important, and it is quite a tragedy that frankly, that we exist in an era where the long-term results of ignoring this very important thing for patients exist at all. So I'm just going to end there and hand off, and I just want to thank again Dr. Castater for inviting me and for being part of this awesome group. Thank you.
Thank you so much for that information, Dr. Joseph. You talked about some issues with screening, and so Dr. Teichman is now going to present for us a way that we can possibly increase screening through delayed screening. I'm very excited to hear about this data. Thank you.
All right, I'm just trying to figure out the sharing here. Okay, can you see my slide?
While you're doing that, I want to apologize for butchering your name. I'm so sorry.
It's all good. No worries. You guys can see my slides, right?
Yes.
Okay, awesome. So hello everyone. I am going to finish this out today. My name is Amanda Teichman. I'm a trauma surgeon at Rutgers Robert Wood Johnson in New Jersey. And thank you so much for the opportunity to sit on this panel. The inspiration for this study is largely from the work done by many of the other members of the panel here today, so it's really a privilege to be here. I'm going to be talking about a PI project that we conducted regarding dedicated delayed intimate partner violence screening at our hospital. And like Doctors Bonne and Joseph mentioned, we were concerned about the non-specific way which IPV screening was being done in our institution. And we felt that it was insufficient. So I'll talk a little bit more about what we did and kind of the results here. Sorry, you can see the right slide, right? The next slide. Yeah, okay, cool. Sorry. IPV is a public health crisis. We've kind of talked about this ad nauseum at this point, but it's true, and it disproportionately impacts our injured patients in the acute care setting. It's estimated that 5 to 18% of patients who present to an acute care setting have been impacted by intimate partner violence, and has been mentioned before, 1 in 9 trauma patients are at risk for IPV. That was based on actually Dr. Zakrison's multi-center study done in 2017. And sadly, I don't think this has changed much. And that's regardless of injury mechanism. There's comorbid factors that put people at risk for intimate partner violence if they're a victim of, or if they are in any kind of accident, even if it's not due to IPV specifically. So as trauma care providers, we really are uniquely positioned to identify survivors and to connect them with resources before violence escalates. And many national bodies have recommended universal screening, EAST being one of them. Thank you so much, Dr. Joseph, for presenting that. But also the Joint Commission, ACOG, ASEP, and others. But unfortunately, implementation is inconsistent, and barriers include, I mean, they're endless: limited time, lack of privacy, insufficient training of clinicians, uncertainty about what to do after there's a positive screen, which is probably one of the biggest ones. So at our center, we realized that simply embedding the intimate partner violence questionnaire into, as Dr. Bonne referred to it, the nurse standing there with Epic with their back to the patient. That's kind of how we were doing it, a broad social determinants of healthcare screen on their arrival. And sure, that was picking up some patients, but probably not as many as it could have. And we identified that as early screening in our study, so I'll refer to it as ES, or early screening. So we asked after that, back in July of 2022, could a dedicated delayed screen perform better when patients are more stable and alone away from their abusers? Could that perform better and improve our identification of survivors of IPV? So in July of 2022, we introduced dedicated delayed screening, or DDS, and conducted it on hospital day 2 or later during our tertiary screening, our tertiary survey. And the providers that would perform this were APPs, residents, even especially medical students, actually. They really, Dr. Jennifer Geller, who's now doing her residency at Jefferson, she spearheaded this quite enthusiastically. Attendings did it as well. But basically what we used was the abuse assessment screen, which is one of the validated tools that Dr. Joseph mentioned. And in addition to that, the people who were delivering the screening had received trauma-informed training prior to delivering screening. And this was focused on privacy as well as compassionate delivery of the screening itself. And so if patients disclosed IPV, we then offered discrete resources through our hospital violence intervention program. And sometimes, literally, as Dr. Joseph mentioned, it was hidden in a lipstick case for our female survivors to ensure their safety. And we hypothesized that this structured delayed provider screen would identify more survivors than early screening alone. So here's the abuse assessment screen. You can see it's pretty simple to administer: 3 questions, one about physical assault, one about pregnancy, and then one about sexual assault. So we retrospectively reviewed all the trauma patients age 15 and older who were admitted during the study period, which was 2022 to 2023. And we identified a little over 4,500 patients with a median age of 54, 61% were male. Our patient population was mostly consisted of patients who had undergone low-level falls or motor vehicle collisions. And overall, about a third had received early screening, and only 4.5% underwent dedicated delayed screening. So even though far fewer patients received dedicated screening, we'll see in a few minutes that we actually yielded a much higher identification rate. And so patients who were screened by DDS were slightly younger. They had longer hospital stays, which is not surprising because the screening occurred later during their admission. Otherwise, their demographics and injury severity were similar between groups, and there was no significant difference in sex, race, or disposition. Our findings suggest that the higher IPV detection rate with DDS is probably not just due to differences in who is screened, but rather when and how they were screened. You can see here that although both ES and DDS were intended to be universal, screening still varied based on injury mechanism. So you can see patients with minor falls were more likely to receive early screen, but those with more complex injuries, such as from motor vehicle collisions, were more often screened later during their hospital stay. And again, while there was no protocol that guided screening by mechanism, there may have been some amount of implicit bias that influenced our practice. Perhaps providers prioritized DDS for perceived suspicious injuries, while IPV amongst older adults who had sustained falls could have been missed. These findings really emphasize the need for standardized trauma-informed screening in all patients. And across all patients who were screened, we found 21 survivors in total. 13 were found through delayed screen and 8 through early screening, with no overlap between the groups. There was no significant difference in demographics, such as age or sex or race or ethnicity. And so you can see here that DDS detected IPV in just over 6% of those who were screened, compared to only 0.6% for those who had an early screening. So there's a tenfold increase. Early screening captured mostly assault victims, whereas delayed screening revealed intimate partner violence across more diverse mechanisms like falls, motor vehicle collisions, and GSWs. This reinforces that we can't simply rely on mechanism of injury to prompt IPV injury inquiry. And really, we need structured and repetitive screening. So here, this is just a little bit of a graphic to see the difference, but I have a few theories as to why delayed screening may have performed better. First, timing and privacy. So by day 2, patients are stable, they're often alone, they're more comfortable sharing sensitive information. Second, perhaps trust. Rapport builds over time between patients and the trauma team. And then third, I think education was really important. The providers were trained in trauma-informed screening, and they potentially felt more confident and approached conversations with more empathy than they would have if they hadn't had that training. And notably, 5 patients who screened negative on arrival did disclose IPV later, showing that, asking again and compassionately does make a difference. So it may not have been just that it was a delayed screen, it could be the act of asking more than once and normalizing the fact that intimate partner violence is so common. May make the patients feel more comfortable and make them feel like this is something we really care about. Um, so we've now incorporated IPV reminders into our daily trauma checklist alongside alcohol as well as geriatric screens to boost our compliance. And again, despite this DDS improving IPV detection, there's still we only screen 4.5% of patients, despite it being part of our protocol. So again, I think barriers like time and inadequate training and unclear follow-up processes still persist. And to address this, again, we've incorporated this into our daily trauma checklist during morning report, alongside all our other PI metrics. And we've actually studied this in alcohol screening and improved our expert compliance. So we're hopeful that it'll have a similar impact on screening for IPV. And so the data is still out on that. So hopefully we will have some positive results. The other thing that is a concern with the study is, although we did provide discrete resources in the form of a lipstick case, probably not the most ideal method for our male survivors. And it really highlights the need for maybe a more gender sensitive and adaptable delivery support method. So if anyone has any suggestions, I will take them. And yeah, so again, all this is a small retrospective study. A pattern is striking, and hopefully in the future we can have some prospective validation to standardize our delivery. So I just wanted to thank our Robert Wood Johnson HVIP team for their support through doing this project, especially to Diana Starris, who chairs the injury prevention, who's the injury prevention coordinator. Carolyn Timmons, who leads our HVIP, and then Elaine Hewins, who is the community intervention manager and has spent a lot of time with victims of intimate partner violence and provided the training to myself as well as to our team on how to best screen and intervene in this space. Yeah, and then thanks to Dr. Jennifer Geller for doing a really good job on this project. She really spearheaded the data collection and screening, and she won the Cox Templeton Injury Prevention Award for this at East this year. So really amazing job, and she's going to do great things. Thanks.
Thank you so much. One common thread across all of these that I was hearing, which I think everyone here on the panel knows, but I will also say for everyone that is attending here, is that in order to really increase screening and detection, we really need to increase safe spaces, decrease stigma, and continue to talk about this topic. So thank you all for being here in order to do that, and also for presenting your data. I do want to quickly just say, thank everyone for attending today's grand rounds. And please, I'm reminding you to submit your sign-in sheets to the AAST office by this Friday, October 24th. We are slightly over time, but I do want to extend a little bit past of the hour, so that if anyone has any questions, they can put that in the chat. So I can just like pause for a second. I haven't seen anything in the chat so far, and so if not, we will be at our conclusion. Anything that any of our panelists want to add now that we've had the everyone present?
I have
All
a
right, well,
question for Dr. Zakrison on her study, and thank you. This is great. You continue to learn just when we learn from each other. In that study, when you looked at you mentioned with the Black women, of course, being disproportionately affected. I'm curious whether anybody has actually looked, and maybe that's where that came from, specifically at certain socioeconomic levels and seeing if then this parity with the results with Black women and other minority women, if that changes or if it starts to approach each other, because it would seem to me almost that it's not necessarily intuitively a function of the person's ethnic makeup so much as it is circumstances. I'm just wanted to know if you had done anything about that.
Yeah, thank you, Dr. Joseph. And so, given the limitations of the NVDRS, I think you can probably whittle it down to maybe, and Stephanie, you probably know this, but maybe zip code. It's hard to get specific granular class-based, like social class-based data for the individuals and that are captured in that database. But what we know is sort of like what I mentioned earlier, that several things that have been mentioned throughout this panel, which is, higher social class, economic mobility, for example, is not a protective factor against intimate partner violence, as you well know, in terms of all people are affected across all classes. In general, within the United States society, in the American context, Black women are at an extreme disadvantage economically because of what I mentioned about pay parity, and even when educational levels are harmonized and they're actually identical, they will still in society earn less, for example, which is exacerbated as years go on. So it's not something we can granularly retrieve from the NVDRS, unfortunately, but it would be worth looking at. I think it's like similar to maternal mortality and birth with, Black and African American women, where is it a function of social class or is it race? And we all know the examples where social class is not protective against structural racism. And I think within the social epidemiology literature, that's shown clearly in a litany and a variety of circumstances where you're not protected even if you have funds or affluence, if you will, like Serena Williams giving birth and being ignored. I mean, so many, those are anecdotes, but that's been shown on a more population cohort level as well. But unfortunately, we didn't look at that specifically with the limitations within our data.
thank you so much. Is there anything that is in actually the Q&A? I don't actually see that, Caitlin. All I see is the chat. And there's been some questions about whether the chat or Q&A feature is working correctly. But I also don't want to keep everyone particularly over time. I know some people are on call and people have things going on.
I think Rashna Ginwala had a question in the question and answer section under answered, in terms of could we share the panelists' contact information if they're comfortable. And I think, Caitlin, you might be able to facilitate that if we're not able to all type the answer in, which we can try to do right now. So Rachna, thank you for that. I don't know, Dr. Castater, if you can see that.
Yes, I now actually do see it.
What I want to say is that, we just have to keep talking and keep fighting the good fight. We're in a very bizarre era right now. Just gotta keep doing what we're doing.
I do want to answer the question, how do we get ACS COT to require a better way to screen and identify trauma centers? I am a future trauma leader with the COT, and my actual charge is this exact question. At the recent COT, we did have a spotlight session on this and are having a number of initiatives that have to do with education and screening, moving towards a future where this could possibly be part of accreditation of trauma centers. So I hope that I see that within my lifetime. I have a strong feeling that I will. I have had a lot of conversations with Dr. Kirby, who's the outgoing president. So more to come on that, but that is very much something that both the college and the COT are working on. So thank you for that question. Is there anything else that anyone wants to say? If not, I really want to just thank all the panelists. Anyone knows that all of these people here are such amazing minds and leaders in our community of trauma and critical care. So thank you so much for agreeing to be here and present your data and your research. I'm very appreciative.